you can see me and the slides.
Yeah.
Excellent. Okay, so what I'm going to kind of do today is I'm going to try and be brief because I normally witter on, but essentially I'm going to talk about giving an overview of introducing technology, the barriers to kind of introducing some of the new tech, and then I'm going to go over my experience of a wearable technology, which I know Harriet from Bron's here. She's going to talk about that a little bit later. So I'm the Chief Clinical Information Officer at Calderdale and Huddersfield, and I'm also a knee surgeon. So some of my experience is from the digital side, some is from the clinical side. So let's start. So the first thing is, I think if anything else, the way that technology has adapted, the way that COVID has brought technology to the forefront, I think now, we are realizing that care pathways must evolve. They can't be the traditional methods of face-to-face consultations, patients coming into hospitals, seeing the clinician. We must adopt and adapt, and we must embrace the new technology and put that as part of our care pathways. We know that technology can enhance outcomes and improve patient care, whether this is through wearables, remote monitoring, whether it's apps or whether it's education. In all these parts play a really, important bit towards the future of how we deliver our care pathways. But it's important that we must align that technology with strategies. There's no good just going to an organisation and saying, hey, this is the new fancy thing that you have, let's bring that in. Every trust, every organisation around the country now has or is embarking on a digital strategy. Any new technology must fit into that and focus. And I think one thing I always kind of say is simple is better. I often see awful lots of healthcare apps and wearables that can be incredibly complicated. And what we know is patients don't need that. For example, in my field, I use wearables for patients recovering from knee replacement surgery. They're in pain, they're struggling. The last thing they need is a faffy app or wearable that takes them ages. And in fact, we have one patient who I think used the wall as a way to get her app wearable to work. And I think, we need to understand our responsibility as clinicians and companies, that we have to, keep the patient at the heart of all we do. It's all well and good making something big, better, but we need to know that the patient is the one that we're doing this for, and the success can only be measured by improvements to their outcomes and satisfaction. So let's look at a few of the kind of barriers that we face. The patient, is why we're here, but sometimes they can be a barrier to introducing some new tech. It can be difficult for patients to accept that, innovation is something that they need to embrace, and when they kind of have that view that the old traditional face-to-face care is the model, and we need to, as clinicians, and we need to as technologists, work with the patients to make them understand that actually technology can improve things. We all know about health inequalities and exclusion, and Dr. Fowler Dean's going to talk about that after this talk. But it's not just the elderly, it's not just those that live in rural areas or those with low incomes. Health inequalities can affect us all, and I think patients have a fear of technology. Again, they don't always embrace it because they fear that it might be too complex, and certainly when they're recovering from an acute illness or suffering from a chronic illness, it's maybe not something that they instantly think is something that they need to use. The clinician can be a real block to technology. Clinicians need to trust the technology, and I don't know, it's certainly my experience as a CCIO, clinicians always blame the technology for something going wrong. Now, I think most of us out there know that computers seldom make mistakes. It tends to be the user, but we need to make the technology simple enough that clinicians can trust it. It is reliable, and can deliver the model of care that they need. There is a reluctance to move away from traditional healthcare models. Clinicians always think that a patient wants to come and see them face to face, when in real terms, patient will much more prefer a virtual healthcare model. And one of the other misconceptions is people think they'll create more work for them. Now, I use a wearable that allows a patient to message and some clinicians don't want to do that because they're worried that they'll suddenly get inundated with messages from patients, or they'll have to be checking dashboards regularly. And again, we need to break down that perception, and we need to also get rid of some of the misinformation and misunderstanding about technology, which kind of fits into the IG concerns, because often with data sharing, there's a lack of understanding of what we can and what we can't do, and people need to realize exactly what we can and can't do. But I think one of the big things is you need to develop clinical champions. There's no good bringing technology into an organisation if you've got no clinician there to drive it, because the clinicians that are the interface between the patients and the boards, and we need them on board. And the organisation, they can also be a hindrance. There's obviously the obvious impact of budgets. Certain healthcare sectors need certain solutions, and they might not be available right now. And a lot of organisations worry about investing in new technology unless they feel 100% that the technology will work, and they don't want to take the risk. And there's differences in the needs and wants of the boards and the clinicians. I'm very lucky where I work that I've got a very digitally motivated CEO that wants to drive technology and wants to drive change and wants to make it part of our organisation. Other organisations are not as lucky, and some, and it needs the board to be involved to drive some of this change. And again, privacy and data sharing concerns are always paramount in any new technology or anything where a patient will work remotely or in the cloud. And again, I go back to the champion bit. When I was to bringing in the wearable technology into my organisation, I remember being shouted at by the medical director, who was telling me that this was dangerous and how could you possibly send a patient home as a day case that had a knee replacement. And and unless I did really believe in the technology and believe in the pathway that we created, I would have given up then. I think that's what we really must focus on, those champions. So the must-dos, it's really simple. You must get the clinical teams involved. It's not just bringing them some shiny new technology. You must look at the pathways that they work with. You must see how the technology will fit into those pathways and how it will adapt for them. Do some of the legwork. I mean, there's nothing worse as a CCIO having to write a DPIA or have to get involved in the clinical safety stuff. So I think if you can get a draft DPIA, have your DCB 0129 ready, most organisations will need those, and I think it's worth doing that groundwork before you go in. And I think anything new, comms and education are the real struggles, and I think if any health tech company can really help with that, I think that's really important. So it's not just about focusing on the technology, it's really focusing on how that technology will improve that patient's journey. And it's not a replacement necessarily, it's about enhancing what we have, and I think that's really important. So what I want to briefly do now is just kind of talk about what I kind of focused on, and this was with BBRON, and I think Harriet's going to speak in one of the breakout rooms. We looked at my knee replacements. I wondered, could technology reduce the length of stay? Could it guide the patient in setting targets and their recovery? Would it free up staff? And could it reduce the amount of hospital visits? And can it improve outcomes? So, I set out questions of the technology before we did, and we embarked on a pilot with BBRON using this wearable app. It's an app connected to the wearable on the Velcro thing that patients wear on the leg, and it monitors their rehabilitation post-surgery. It can set goals and set targets. It allows the physiotherapist or the clinician to look into the dashboard and see how a patient's progressing. And it allows you then to act if a patient's non-compliant. It allows you then to call the patient back for a face-to-face appointment, or you can simply see them virtually if you have no concerns. But I think one of the big wins is the patients could message the therapy teams. So we also introduced follow-up using video consultations, which I think when we started was quite unusual. I think now, obviously, because of COVID, I think it should be kind of the norm now is we're doing video consultations, and what we've now adopted is a bot from Andor, which allows us to really seamlessly use Microsoft Teams for our video consultations. But having the wearable gave me the confidence to know that I don't need to examine that patient at the 6-week stage. I could reliably know how their outcome was doing and how they were achieving their results. So we ended up with 23 people in the pilot, and contrary to what most people thought, 62% of those people actually complied daily with the exercises using the wearable, which again, and this is a patient mix, from the elderly to the not so elderly, and I think the majority of patients did comply, and I think that was, what we found is that if they complied with the technology, they got better outcomes, they had better range of movement, and they recovered quicker. And I think that, that was really kind of an important message, that technology is not something that's kind of left in a drawer. People do engage with it if they've given a reason for that. The benefits we saw for therapy, they reduced the amount of appointments that they needed. There was a significant cost saving, just nearly £1,500 just to this small pilot. And our physiotherapists now feel they can completely reduce this much further, to a point where they can now go completely virtual with the majority of care. And I think the hospital benefited. There was a reduction in the length of stay, which in itself reduces cost, but I think more importantly in the COVID era, reduces the amount of touch points a patient has with the hospital, which can only be a good thing as we maintain social distancing. And the patients, they loved it. They loved being part of the team. And I think that's what technology gave them. It gave them that kind of feeling that somebody was watching over them, somebody was with them. And I think that made them part of this kind of pathway and part of this team. And I think that made a real improvement to their outcome. They used the messaging service really well. There's a lot of messages went out over that small cohort of patients, and it was really simple answers and really simple questions, and that was enough to give them reassurance. So I think, the benefits to the patients kind of, was significant. And I think it just shows you a really simple wearable technology like this, gave us some real benefits. So this is some of the feedback. Patients liked it, they felt supported, they used it regularly, and the physios could see the progress. So physios were much more confident to keep a patient remote. So the benefits of what we did: increased satisfaction, better outcomes, reduced bed days, although we're pushing the patient further away, the patient felt closer to us, and we reduced the cost of care. And the good thing about this, it can be shared with other organisations, and I think that was one of the big messages that we had. So I think I've hopefully kept the time there.
You have indeed, and you've gone under just by a minute or two, but that's perfect. I mean, there's lots to go on there actually. Just to remind people, we are going to have a facilitated discussion at the end. I mean, it sounds fancier than it is, but opportunity to ask questions. So I don't want to try and do that now, but just to remind people, put any questions in the chat, and we'll try and tease these out, because that was brilliant, Graham. Thank you for doing that. And I think there'll be lots of things there that people on the call, as both organisations with innovation, will welcome that feedback. I think starting off small, getting the confidence, getting the trust, getting the clinical champions, really good sort of must-dos, and those questions that you sort of set out, really nice and simple to a certain extent. So brilliant. So if you can, stay on the line. I'm sure Graham would love to answer any comments you've got later on. Or if not, we can connect you after this event as well. So let's stick to time, and then we can eat. Well, we can get a bit of time back potentially, and get ahead of ourselves just for a short break. I'm going to hand over now to Sally Fowler Davis, and Sally, I'm going to share your presentation for you. So let me just do that now. Is that okay, Sally? Can you see that? Is that working?
I can, but if you want to just put it on the normal slide share, then everyone can.
I've only got it in PDF, sorry.
Oh, no, that's fine. That's fine. I don't know if it gets bigger than that. Yeah. OK. Shall I make a start then?
Yes, please do. Yeah, thank you.
Thanks, Pete. Thanks. And thanks very much, Graham. That was really, really interesting. And I guess, I'm always interested when you're invited to an event like this, and the AWRC are very keen to be involved with the Academic Health Sciences Network, but I can see that what they're doing and what they're contributing, what you're doing with this event, perhaps, Pete, is pulling together a group of people who are really, really willing to learn and share that learning around technology and technology deployment. So it was very helpful to hear from Graham about that focus on piloting and keeping the patient right at the centre. So some of my presentation is going to kind of chime with that very closely, but obviously I'm going to put forward a little bit more about how the potential of rehabilitation, particularly in partnership with industry and with technology, could really, I think, tackle health inequalities. And that's what I'm going to say is the #1 driver going forward. So as requested, I'm just going to start with a quick introduction to myself and to the work of the AWRC, just for a quick 5 minutes, because I think we would like to hear from and know and be in partnership with as many providers and interested clinicians as we can as we go forward. This is one of our key agendas. So next slide. Just to let you know that I was an occupational therapist and about what feels like about 100 years ago, and I have been working in academic practice for quite some time. I have a research leadership role within the AWRC, what we call the portfolio, and our vision is to transform lives through innovations that help people move. Now that can look very much like a physical activity goal, and of course it is. We're very interested in physical activity, but I guess what we're really trying to do is prevent and treat chronic disease. And I talk a lot about secondary prevention. So rehabilitation and secondary prevention are almost synonymous, really. It's the idea that we're really trying to create a better standard of health for people in spite of multiple morbidities very often. Okay, next slide. So what we do, the AWRC is about bringing together world-class expertise, multiple academic disciplines, really interesting multi-interests, right through from technology through to the arts. We're really focused on collaborating as a community, internally and externally, and across, if you like, the research hierarchies. Many people would say, and it's much enshrined, if you like, in the work that we do, that a randomized controlled trial is the only strong evidence we have. But actually, and in keeping with my focus on population health, often we really need to look at that lived experience of an individual who's adopting technology. Next slide. So you can see that we have state-of-the-art facilities, and we're really curious in 3 key, what we call impact areas. One is looking at physical resilience across the lifespan. So although Healthy and Active 100 really learns from that book that many of you will have seen, The 100-Year Life, it's a really stimulating psychological text about how we need to re-envisage our futures right from childhood, really, in terms of how we activate ourselves. We have another theme called Living Well with Chronic Disease, so really in keeping with what Graham's been talking about how we incorporate technology in a pathway. And then a specialist unit, which is really looking at the advancement of robotics and multiple AI functionality, I suppose. We're really interested in this idea of not collecting one measure, but a minimum data set, and using artificial intelligence to understand that perspective from multiple different angles. So a lot of our work with our partners who've been on the accelerator, next slide please, have been involved with these themes. Now, there's a couple of other things to say about the AWRC. One is placing the person, the individual, at the heart of our research is absolutely a core principle. But when we talk about an individual, there are multiple individuals, and very soon we'd start talking about populations and communities. Next slide, please, Pete. And I think this is never more true than the work that we do at the heart of our community, which is in Darnall, which is one of the most socially disadvantaged areas of the city. So we were a kind of glitzy new building at the heart of the Olympic Legacy Park, and that footprint was not incidental. It was aspiring for regional development. It's aspiring to demonstrate a commitment to a side of the city that's probably been under-resourced over years. And it's about bringing health and well-being right to the heart of that community. Next slide, please. So how do we drive economic growth? The AWRC has been really fortunate in getting £900,000 worth of funding at its early stages to create instrumental indoor and outdoor laboratories.
Right. Oh, sorry.
Shall I carry on?
Yeah, let me just put my...
Competing with the dog. That's okay. So we really, we're fortunate insofar as sometimes you just need these spaces to help you investigate and to look at the practice that you're wanting to put into place. So just a couple of things about the accelerator, and next slide, is that we are now in the back end really of our accelerator programme, but it is absolutely at the heart of what we're doing. The programme has delivered to 28 startup companies who have benefited from £20,000 of R&D support each, and some of those programmes will be described to you here today. And it's really important, as next slide, it's really important to recognise that around that programme we've developed a kind of community of practice, I think you would call it. Programme partners, mentors, experts in the field, and very significantly and often through my systems level work in implementation, through more than 100 partners in senior roles, not unlike Graham's, across the whole of the Yorkshire and Humberside footprint. And we absolutely pride ourselves, if you like, on this connectivity and investing, I guess, in this notion of co-production. What works for whom and in what context? That's our kind of rationale. So that's a little bit more about the accelerator, and it would be really great to hear from, I know there are partners here from the academic side and from the commercial side, so I'm looking forward to hearing from them about what they've felt has been useful and what we can learn, I guess, and scale up in terms of the accelerator. So next slide. So back to my agenda. I really want to just kind of reinforce a couple of principles, I suppose, strategic principles about how rehabilitation and the digital and data transformation is all about developing better health outcomes for the whole population, and about how this is actually in every way now, I hear, the #1 strategic priority, and how as a group of leaders we really do need to come together now and look for innovations. And it's not insignificant that we talk about, Graham and I are both talking about adoption, and in fact the CQC have just published a really formative report about innovation adoption across the whole integrated care footprint, because this is the current kind of problem, I guess, that we are really all now wanting to face in the post-COVID landscape. Next slide. I want to just offer you this presentation, and it might be something, this rainbow might be the kind of slide that you've seen many times before. It's certainly very familiar if you've got a background in public health. But we talk now about population health being about managing social determinants. Managing the inequalities in population health is now the priority, as I say, and we talk about levelling up access to services. And I guess I'm putting this slide up because when I do share this with colleagues in digital industries, it's not actually that familiar. But when we're talking about rehabilitation, we are recognising that one of the fundamental principles behind rehabilitation is what are your life chances? How well can we enhance your recovery, but also your life chances in relation to that recovery? So we know that's about age and gender. It's about individual lifestyle factors, social and community networks you have. In public health, we talk about having a job, a home and a friend. Really fundamental connectivity in your own personal existence that allows you and makes you want to actually be aspirational in terms of your health. I'm doing a piece of work at the moment around long COVID in an underserved community in Sheffield. And what I've been very struck by is how many underserved communities, deprived communities, actually just deprioritise their health needs in the space where they have many, many other competing priorities. So this is a really important diagram by way of our strategic understanding, our shared strategic understanding of what rehabilitation is really about. It's a principle that I think I often ask colleagues, entrepreneurial colleagues in industry, to kind of share with me, to look at what sort of data can you provide me with as part of your innovative product or tool, which allows me to say something about this inequality that we recognise within healthcare, because this is the growing edge of what we're doing within rehabilitation. So next slide. Rehabilitation research and design then is really underpinned by this potential to level up in relation to health and care. We really want to measure and monitor different outcomes so that we can see where the differentiation is between old and young, or older and younger, people with and without really supportive infrastructure. And we want technologies to measure what matters to individuals. What matters is actually a very fundamental economic value-based measure for technology, and we are going to have to move away in rehabilitation from a one-size-fits-all approach, and this is where personalised care and technology provision just really sit hand in hand. We know that poorer communities, more deprived communities, simply don't engage with rehabilitation in the same way that wealthier and more health literate people do. So we need an opportunity to provide better access to some of our communities, digitally and in other ways. And of course, we're working towards supporting the integration of care provision. Next slide, please. So lots of rehabilitation professionals are here today, people who really get the idea of co-defining what matters to users and service users, who are really trying to put into place tools that can show a change in health outcomes. But there are difficulties around this. We want things, as Graham perfectly said, and I completely agree, we want things that are easy to adopt in practice, normalise in day-to-day routine activity, and get past some of the known barriers, although older barriers now, around just sort of people saying, patients need people contact. In Sheffield, we've done a lot of work to reduce the number of outpatient clinics, and that's actually going to go on and on now as we move into the community. I'm just going to speed up a little bit. But there are some really big problems. Rehabilitation professionals are impacted by a very weak capacity to deliver operational data sharing. Only 25% of integrated community care is supported by a shared patient record. So there's some real levelling up to do here in terms of our public health infrastructure. We can't measure population outcomes if we don't have these shared records. And there are sort of shared barriers to this, where we need to work in real time using operational data. And that is absolutely the space that the Academic Health Sciences Network is supporting. So I think I can probably just summarise now that there are lots of examples of technology projects that I've been involved with over the years that have failed, partly because one of these four factors, often to do with commissioning and procurement, in the final, the goodness of a product is not really measured appropriately. It can be high quality, it might be affordable, it might be exactly what we want, but commissioning and procurement is obviously the final answer here. I'm going to move on. Just wanted to show you an image of some work that we've been doing in Sheffield, just to highlight the fact that health inequalities are now on the agenda in the post-COVID era. In Sheffield, there can be a 15-year difference in healthy life years. And this is shown by this heat map. You can see the areas of deprivation are the darkest red, and these are the areas that have had the highest rates of COVID and now have the highest rates of post-COVID or long COVID as we talk about it. It's also the areas that we're really trying to use different technology tools to reach into these populations in S2 and S9 and S5 as part of our work. And that's only going to become more so. There's a real important principle here, I think. We have to test locally and scale up. So that's why it's so important that, you know, individual projects are really carefully evaluated and looked into. Okay, so to conclude, you know, we're all behind the technological revolution, but we do want to design in recognition of the high variance in access to hardware and broadband. There is IT poverty out there, and that's not just in individual homes, that's in whole services. We want to look at outcome measurement as a priority now, not just how many interventions we've managed, but actually what's the effect? And this area is a little bit underdeveloped in my view in technology. We want to show where there's been a health improvement and a health outcome, and that would be an enormous asset to any product that we looked at. And rehabilitation and secondary prevention are the mechanisms to enable that personalised care. So there are opportunities ahead. We really, I think we have yet to see the really scalable transformation of technology in healthcare. But as I said, there is a really interesting, very, very current piece of work by the Care Quality Commission, and I couldn't put it better myself. Enabling innovation and adoption is really what we need in order to scale up to population health benefit. So sorry for going over. I've just taken those minutes that Graham saved us, Pete.